Good evening, everybody, and welcome. My name is Carol Fox, and I'm the co-director of UCSF's Mini Medical School, which is brought to you by the Osher Lifelong Learning Institute here at UCSF. MiniMed is always a popular UCSF program, and we're delighted to see so many of you here tonight. A lot of you I know are people who have been to our other MiniMed courses, so welcome again. We've designed MiniMed to take you through a consolidated version of the core curriculum for second-year medical students, and the course is taught by the same distinguished faculty here at UCSF who teach our medical students. This year's MiniMed is structured around the medical students' I3 course on infection, inflammation, and immunity. These biological processes are the core of a large number of the world's most pressing health problems, and the course will cover key topics in microbiology, immunology, infectious diseases, and international health. We're privileged to have as our opening night speaker Dr. Warren Levinson. He's a professor of microbiology and immunology here at UCSF. He lectured at our first MiniMed program in 1999, and so we're delighted that he's consented to come back and do a return lecture for us. It's a different lecture, but we're glad to have him. He joined our faculty here at UCSF in 1967, and he's received many of our distinguished teaching awards here on the campus, including Outstanding Faculty, Major Contribution in Teaching, and Inspirational Teacher Awards. So I think we're in for a treat tonight. He's been the leader of our Microbiology and Infectious Disease course for the medical students since 1981. And he was also instrumental in helping us put together this course. We had long conversations on the telephone about what should be included in the course and who our speakers should be. As a matter of fact, our speaker for next week, I understand, is hiding here in the audience, in the back. Dr. Levinson is also an author, and the 9th edition of his textbook, which is right here, Medical Microbiology and Immunology, for any of you who want to purchase it, was published earlier this year.
You want to be put to sleep.
I didn't mean a commercial. But it is one of the best-selling medical textbooks of its kind, and it's been in publication now for a number of years. So since it was just published, we know that we're getting the most up-to-date current information that there is to be had on this topic. In his non-academic life, I always like to know what people do in their off time, so we always ask. I think in the bios that were provided to you, it says that he was on the City Council of Mill Valley for a number of years and was also the mayor of Mill Valley, for those of you who might be from Marin. And I also learned today that he and his wife are ballroom dancers, and that they just got back from Argentina, where they did the Argentine tango and have been doing it since. So that's probably a topic for another lecture.
Right.
But I always like doing these introductions because I learn a lot of fascinating things about our faculty that you don't hear otherwise. And please join me in welcoming Dr. Warren Levinson, who will tell us about how bacteria cause disease. Thank you.
Thank you. Thank you very much for that kind introduction, Carol, and welcome to the first in this series of 6 lectures on infection, inflammation, and immunity. So as Carol said, I am the leader of this course for the second-year students, and in fact, they just had their final exam yesterday. Pleased to say that they all did well. So one of the tasks of the first speaker in a series is to set the stage for the remaining lectures. And so for the first portion of this talk, I'm going to describe to you the world of microbes, all of the organisms that cause human infectious diseases, and I'll show you how they differ and compare and contrast them. We'll then move on to infectious diseases themselves and how physicians think about them, and describe many aspects of their the pathogenesis, the way in which disease is caused, and then move on specifically in the last section to how bacteria cause disease, and you'll see the various ways in which that happens. So let's address the first thought and to emphasize to you the importance of infectious diseases. So here are the causes of death worldwide. It's a little bit out of date, but the data hasn't changed very much. This is from World Health Organization, and you see at the top of the list is infectious diseases, infectious and parasitic diseases, but basically infectious diseases worldwide, more than cardiovascular diseases and cancer put together. Now, that's not true in the United States. Infectious disease is much less important, but worldwide, we are talking about the most common cause of death, just to emphasize the importance of these infectious diseases. So now let's talk about the cast of characters, as I've termed it. So starting from the most complex, the largest group, we have the worms, and I'll show you a few of those. And I see some faces scrunching up at that. And then we move lesser complex, smaller, the protozoa. Again, I'll show you examples and discuss each of these. Then the fungi, and then bacteria. We're getting much smaller and much simpler. And lastly, the virus is the smallest of all of them, and I'll show you images of all of these as we go along. So here are the microbes that cause infectious diseases. We have the animal world. We have the worms, technically called the helminths. So they are eukaryotic, meaning that they have a true nucleus. The DNA, the chromosomes are inside a nuclear membrane. There's a cytoplasm and a cell membrane. They are sort of classic eukaryotic cells. And as worms, they are multicellular, many cells. And so the organism that you know is the tapeworm, and I'll show you a picture of that in a moment. There's also the roundworm, the ascaris, also very important and widespread. Hundreds of millions of people throughout the world are infected by these organisms. So here's the tapeworm. So now you see why it's called the tapeworm. Looks like, in fact, a long tape. The one interesting comment is that this little head is how it attaches to your intestinal tract. And then these multiple feet long worm, and here's, for example, this is one of the segments, here's another segment, and you can see the outline there. So the hundreds of segments of these, what are technically called proglottids, now make up the body of this tapeworm. And here's the roundworm. So we're now, this is colonoscopy. We have a scope in looking, and here's the person's intestinal tract. And what is that? Is that a roundworm, that has now living in this person's colon? Yes, it is. And when you treat someone with these roundworm infestations and paralyze the worms, and then they expel these worms, these are the worms from one person. So when you read in the paper about the worm burden, you see where that term comes from. Imagine trying to function, trying to do a day's work or be productive with this worm burden in your intestinal tract. Now, a few of these worms, just parenthetically, don't cause symptoms, but when they are of this magnitude, then intestinal obstruction or something similar may result. Okay, so now we're moving again down the scale both in size and complexity. Here are the protozoa, which are eukaryotic, true nucleus, but now are single cells, in contrast to the worms, which are multicellular. These are now single cells, and they have the capacity to move. And the organism you know is Giardia. You're very familiar with that. The term you might not know is Plasmodium, but it's the cause of malaria. And I'll show you images of those. So here's Giardia, single cell. Here are the flagella that allow it to move. And here, these are the suckers by which it attaches to your intestinal tract mucosa, thereby disturbing the intestinal motility and causing the watery diarrhea so characteristic of Giardia infections. Here's Plasmodium, the cause of malaria. And here it is in the red blood cells. All of these structures are in fact the organism, the Plasmodium that causes malaria. This is a so-called signet ring stage for obvious purposes. Here's the little gem, and here's the ring portion called the signet ring stage, very characteristic infection now. So again, single cells, protozoan parasite. Moving now to the other group of the fungi, they have a true nucleus. They are single cells, but now they are non-motile. They don't move. They don't have flagella. And the single cells that reproduce now by budding in the yeast category, and molds that reproduce by mitosis. I'll show you examples of each of these. The organism that you know is Candida, which causes thrush. Many of you who are familiar with that term. But the organism, because it's such a beautiful yeast form that reproduces by budding, is Cryptococcus, very important cause of meningitis, particularly in patients who are HIV infected, who have a low CD4 count. Now, so here's the body of the yeast, and here's the little bud. So this is unequal division. It's not mitosis where one cell makes two identical daughter cells. These yeast reproduce by producing a little bud. And so that's characteristic of the yeast forms. The mold forms, on the other hand, are long filaments of cells, technically called the hyphae, that reproduce by mitosis, where one cell makes two. And the organism that you know, because it's the green mold on the orange that sits in the back of the refrigerator for a month or two, you've all experienced that, is Aspergillus. Very important cause of human disease. Now here it is under the microscope, and these long hyphae, long strands, each one of these is a single cell divided by these little cross walls, or septa as the technical term. Let me just parenthetically say, what I think is really remarkable is that some fungi have the capability of switching back and forth between these two modes. Absolutely remarkable that it can, as a function of temperature, be in the mold form in the soil and in the yeast form in the body. And organisms that do that, you heard of valley fever, coccidioidomycosis, can change its shape in this fashion, as well as histoplasmosis. Those of you who come from the Ohio, Mississippi valleys, you know that histoplasmosis is very common there. That organism also can change its morphology, change its shape, change its appearance, mold form in the soil, and a yeast form in the body. It's absolutely remarkable capability of these organisms. Okay, so now moving yet further down in size and complexity, we have the bacteria. And again, we're going to focus on that a little bit later. But these now are prokaryotic organisms. So these now don't have a true nucleus. They don't have a nuclear membrane. The chromosome lies free in the cytoplasm. A much simpler organism, yet you'll see how complex and sophisticated they are when we address them specifically. And they reproduce by binary fission. And I'll show you a few. Here's Streptococcus. You're all familiar with strep throat, or the flesh-eating Streptococcus that ate my arm when you're at the checkout counter. Okay, so this is the Streptococcus. So here, these are our red blood cells. Here's one, here's another. And these small blue spheres are these streptococci. Strepto means chains, so you can see that these are in chains. Here's quite a long chain, some short chains. Very characteristic appearance of these streptococci. So bacteria, again, much smaller than our human cells. And lastly, in our description of the organisms that cause human disease are the viruses. So they are non-cellular. There's no cytoplasm, no nucleus. They are non-cellular and grow only within cells. They are what we term obligate intracellular parasites. That is to say, it is obligatory that they enter cells, intracellular, within cells, in order to make more of themselves, in order to replicate, in order to grow. So one virus enters a cell, and 1,000 or 100,000 progeny viruses are produced. A much different mode of replication than binary fission or mitosis, where one cell makes two, or even budding, where one cell makes two, but of different sizes. This is now a completely different mechanism or mode of growth, of replication. So again, viruses, non-cellular, grow only within cells because they do not have the ability to make their own energy, and they do not have the ability to make their own proteins. They depend on our cells to make the virus proteins. So they, again, are obligate intracellular parasites. Well, because viruses are so fascinating, I just want to spend a moment on them. Normally we think of viruses as something very small and have some rather hazy idea and think that they're quite simple, but in fact they are remarkably complicated and interesting. Let me just give you a little bit of a feeling for that. So here's E. coli, which you're all familiar with. It's been in the news vis-a-vis the spinach outbreak. So here's E. coli. And here's one of the smallest bacteria, called chlamydia, cause of sexually transmitted disease, very important. And here are the viruses. So on this side are the DNA viruses that have DNA as their genetic material. On the right-hand side are the viruses that have RNA as their genetic material. And let me make one point, and that is, viruses are the only place in the biological world where RNA is the genetic material. All other organisms, the worms, the protozoa, all of the other ones that I've mentioned so far, use DNA as the genetic material. Here's a whole group of viruses, and I'll give you some names in a moment, that use RNA as the genetic material. Completely new and different idea. So here we are, as far as size is concerned. Here's the chlamydia, one of the smallest bacteria, one of the smallest free-living organisms. And here are the pox viruses. So-called smallpox virus is the one that you're familiar with, although molluscum contagiosum virus, which some of you may have heard of, is also a member of this family. And here's its DNA inside a little protein coat, and having these special structures here. So immediately a little bit more complex than one might think. And then here's herpes viruses. Again, the DNA is centered inside this protein coat with an envelope surrounding it. Here's adenovirus, the cause of sore throats and pneumonia, looking very much like a lunar landing device with its fibers sticking out from the surface. Here's the papoviruses, human papillomavirus, which you've read in the paper recently. There's a vaccine now against this virus. This virus is the cause several strains of cancer, carcinoma of the cervix. Very important now to have a vaccine against that virus. Falls into this category. And then lastly, the parvoviruses, the cause of slapped cheek syndrome. Some of you may have had children with this disease, where the cheeks of the child now are quite red. It's a minor disease, unless it occurs in a pregnant woman who can transmit the virus to the fetus, but that's another story. The point I'm making is not so much that you remember which organisms these are, but look at the size difference, at least a tenfold difference in size, and the complexity of the structures. And similar situation here on the RNA viruses. The viruses of measles and mumps fall into this category. This is rabies virus. It looks very much like a bullet. That's the way we describe it. Here's influenza virus, poliovirus, and human hepatitis A virus fall into this category. The thought is, again, that these viruses vary significantly in their size and complexity. They are not just simple little items. They're much more complex than we normally think of. Here's influenza virus, very important these days, the threat of avian influenza. So here it's RNA coiled up in the center, surrounded by a lipid envelope, and then these spikes protruding from the outside, and that's the way the virus attaches to our human cells through these proteins that protrude from the surface. So contrast, I'm just going to give you two examples, contrast that with the appearance of Ebola virus, the cause of hemorrhagic fever in Africa, lethality of perhaps 50%. So completely different in its appearance. Long rods, very long rods, with the RNA. You can almost see the central structure here, and the RNA is coiled up inside in a helical fashion. Again, just to give you a sense that viruses differ greatly in their size and complexity. Okay, with that introduction of the organisms that not only I, but others in this lecture series will be speaking of, let's move on to the infectious disease and begin discussion of that. So why do people get infectious diseases? So I've structured it such that there are factors that are innate or belong to the organism, and then factors that we have, host factors. That the host factors will be discussed in the immunology lecture, but I just want to touch on the fact that we have both innate defenses that are present all the time, that are active immediately, and that are non-specific in the sense that they don't care whether it's bacteria X or bacteria Y or virus X or fungus. They recognize it as foreign and engulf it and kill it. That those fall into the innate category. And then the adaptive categories are antibodies and T cells, which are exquisitely specific for that particular virus and even that particular strain of that virus. Remarkably powerful and highly specific. So we basically have the front line here, the initial defenses that say, whoa, wait a minute, I recognize you as foreign, and I'm going to engulf you and destroy you. But if the dose of the organism, the numbers of organisms, or if the particular virulence, and I'll define that on the next slide, is so great that it overwhelms our host defenses, then, as it says, infectious diseases occur when organism factors overcome host defenses. It's fairly obvious, but I just thought I would say it for the sake of completeness. So let's talk, since the focus of this talk is on the organism, and let's just say a word about dose and virulence factors. So the dose, obviously, is the number of organisms. And again, a truism, the higher the dose, the greater the risk of disease. Nothing much new there. But what is new and interesting is virulence, because this is now the ability to cause disease, which varies greatly from organism to organism and within a particular organism. And that's going to be a recurrent theme, and I'll emphasize it as we go along. And it depends on the individual organism's ability to produce these various virulence factors, such as the capsule, pili, exotoxin, endotoxin, glycocalyx. These are technical terms. I'm going to define them and show them to you. I just want to introduce those terms now at the beginning. And they are often encoded on plasmids, which are extra chromosomal DNA. And I'll emphasize, I'll show you an example of that. But the thought is that here's the DNA of the bacteria, and that is sort of what it begins with, or the starting point, and then new pieces of DNA can enter the bacteria through a variety of mechanisms that I'll describe, and endow that organism with new characteristics, new traits, new ability to cause disease, new ability to make virulence factors that makes the organism a more aggressive pathogen, more aggressive in its ability to cause human disease. So this is one of the most remarkable images in all of biology and all of medicine. So this is E. coli, and it was ruptured, and the DNA was allowed to exit the organism and then stained in a particular way in an electron micrograph. So all of this is the DNA of the bacteria. And just think about the packaging aspect. All of this DNA has to get back. It came from this organism. I mean, that's quite remarkable in and of itself. But wait a minute. What's that? And what's that? And what's that? Are these plasmids? Are these extra chromosomal pieces of DNA that can carry the genes that encode the virulence factors that I've just been talking about? The answer is yes. They not only encode the virulence factors, but also encode antibiotic resistance. So when an organism becomes resistant to an antibiotic, it is often because a new plasmid has entered the cytoplasm of this organism and now has caused the production of various enzymes that provide antibiotic resistance. So again, here's the DNA of the organism, but there are these additional pieces of DNA that this organism and this organism only has acquired. Okay. Say a few words now about how we think about infectious diseases, because it tells us a little bit about how you as a person can think about it, but also how physicians think about these diseases. So the incubation period, you're all aware of that term, but let me define it, and it has some implications. So it's the period during which there are no symptoms. But the organism is growing and often spreading systemically throughout your system into the bloodstream and into various internal organs and sometimes even to the skin. So a lot now can happen, but there's no symptom. You don't even know that you are going to be sick. Now comes the prodromal period. Very important idea that there are non-specific symptoms of fever, loss of appetite, just not feeling well, muscle aching, and we are often able to communicate the organism during this stage. It's a very important concept in terms of public health, i.e. people typically go to work at this time, people interact with friends and so on, but yet are often communicable, i.e. capable of spreading the organism at that stage. Then comes the stage of specific illness. We get a rash, measles, chickenpox. We get a cough, pneumonia, diarrhea from some viral or bacterial pathogen. Depending upon the organism, we are also communicable at that stage. And then we get better. Symptoms are resolving. But now the amount of antibody in our blood is increasing, and this is often used as evidence that we have been infected with that organism. It's a very important idea that during this time, let's say we have a diagnostic dilemma. We've tried this and we've tried this and tried to diagnose, and we've taken blood and analyzed this and analyzed that, and we haven't made a diagnosis. So not common, but an important idea when needed is that we take a blood sample now, and then a week later we come back and take another blood sample and ask whether the amount of antibody against that specific organism has increased to a significant degree, and if so, that patient was infected with that organism at this time. So an important idea that during the convalescent period, if there's a diagnostic problem, then the rise in antibody titer can be very useful as far as diagnosis. Intuitively, you would think, oh, person's getting better, they are less communicable. That is certainly true. And then the period of recovery where health is restored. But we should always remember that there are some diseases where a chronic carrier state occurs. And you're all familiar with typhoid Mary, who had the Salmonella typhi organism in her gallbladder and then excreting in the bile into the GI tract, so that she was now spreading the organism to, she was a cook, okay, and so she's preparing the food, and an outbreak of typhoid occurred in people who ate at her restaurant. People with hepatitis B and hepatitis C are often carriers of those particular viruses. So we need to be aware that at least with some diseases, people can be chronic carriers, and think of the important public health implications of that, and of knowing that, and then of educating the person about health habits and hygiene, washing hands, not sharing toothbrushes and things of that sort. Does my patient have an infectious disease? Let's address that question for a moment. So fever, well, we all recognize that fever is an accompaniment of infection. However, let me quickly point out that of the big three diseases, big three categories of diseases, infection, autoimmune diseases, and malignancy and cancer, something like 80% of all diagnoses fall into that category. All three can manifest with fever. So fever is a very non-specific criterion. Well, what about inflammation? I'm going to say more about inflammation in a moment, but you all know that something is red, swollen, tender, warm. Well, those of you who know someone with rheumatoid arthritis, an autoimmune disease, know that the joints, in fact, are inflamed, and yet this is not an infectious disease. This is an autoimmune disease. So even inflammation is not, by definition, or very useful as far as making a diagnosis of an infectious disease is concerned. Well, what about an exudate or a discharge? An exudate, let's say pus, and I'll have more to say about pus in a moment. So we have an abscess was filled with this fluid, or exudate is the technical term, or sputum, someone is coughing up sputum, or a urethral discharge or a vaginal discharge. Now we're getting into something that is more specific for infections. And then lastly, an increase in the white blood cell count in the blood often occurs in infection. So putting all of these together, if a person has this constellation of findings, I think we can, with some confidence, using these criteria, say that we should investigate this problem from the point of view of an infectious disease. Let me move now to address inflammation. Since we have infection, inflammation, and immunity, let's talk a little bit about inflammation for a moment. So inflammation is the body's response to the presence of an infectious agent. The affected area is red, warm, swollen, and tender. And let me show you rather dramatically, this arm is inflamed. Even you would admit that and could make that diagnosis. So this is streptococcal cellulitis, streptococcal skin infection, where the Streptococcus organism has now gotten both into the skin and under the skin and has spread rapidly throughout the entire arm. Let me go back for a moment. But inflammation is a two-edged sword. On the face of it, you would say, no, this is terrible. This inflammation is causing pain, obviously discomfort, limitation in motion. But it, in fact, has a beneficial component. You say, well, I don't understand. How could that be? In that the redness and swelling reflects increased blood flow, bringing phagocytes and antibodies to the site of infection. So, in fact, it is part of our host defenses to bring these beneficial components, phagocytes, antibodies, there are other things, complement a whole variety of other components of the blood, to the site of infection. However, it is detrimental in that the symptoms of some diseases result from the inflammatory response. But the underlying idea is that this is a beneficial host response trying to combat the infection. So how does this work? So here on the left is the normal situation, the non-inflamed. So this is the tissue. Here is the very small blood vessel carrying red or oxygenated blood. And here are the capillaries. And here, this is the surrounding tissue, and occasionally there's a lymphocyte or a macrophage. Macrophage means big eater, macro, big, phage, to eat. So it is a big eater in two senses. One, it can ingest and kill many different organisms, but it is also a large cell, a macro cell, larger, maybe half again as large as many of the normal white blood cells. So this is the normal situation. So now, should there be the presence of a bacteria or offending organism, the area now becomes inflamed. The arteriole is larger, so more blood supply, that's why it's red. More blood supply, that's why it's warm. More blood is coming to the area. And more white blood cells now emigrate, exit the blood vessels, and now get into the tissue where putatively there would be a bacteria here or there, and now this neutrophil, and I'll just describe the various blood cells in a moment. But this is our major, in addition to the macrophages, our other major phagocytic cell, now emigrates and now engulfs and hopefully kills the offending organism. Here are the capillaries, and in the process now of this inflammation, fluid leaks out from the capillaries into the tissue spaces, now causing the swelling. So we have explained the redness, increased blood supply, the warmth, increased blood supply, and then the swelling from increased fluid migrating from the blood vessels out into the tissue spaces depicted here. So again, inflammation being now looked upon as a beneficial act on the part of the host to defend against these organisms. So here's a good example of inflammation. It's now an abscess, which is a walled-off area of pus. This is from a recent issue of the New England Journal. Here's this man's inner arm. It's obviously inflamed. There's an abscess containing pus inside this lesion. And let me show you another example now of pus. I want to address what that word means. So here's a brain, cross-section of a brain, containing an abscess, actually two of them. And notice that the inner lining of an abscess is a walled-off area of pus. You can see the thick wall here. And this greenish mucoid material, which in fact is the pus. So what is pus? Something you might have asked yourself. Maybe not every day, but occasionally. It's a mixture of bacteria, human cell debris, and the phagocytes. So the phagocytes that are coming in there to engulf and kill the organism. And the phagocytes almost always are neutrophils. And again, I'll describe those in a moment. But one question that I always get from the medical students is, why is it this yellowish-green color? Well, turns out we know. The neutrophils contain or possess an enzyme called myeloperoxidase that's involved in the killing of the ingested bacteria. Myeloperoxidase makes the hypochlorite known to you as bleach. So bleach is a very important oxidizing agent, killer of microorganisms. So inside these neutrophils is an enzyme that's making a tiny amount of hypochlorite, a bleach, that's actually going to kill the ingested microbe. And well, it turns out that myeloperoxidase, when you purify that enzyme and have it in a test tube, is green. And that's the reason why pus has that yellowish green color. I promised you a description of some of these blood cells, very important in infection. So here are the neutrophils. This is the terms, the names are based on the color of the granules in the cytoplasm of these cells, because the color is determined by the contents, the nature of the contents. So here are our red blood cells, and here is a neutrophil By the way, these are the lobes of the nucleus. The nucleus now, instead of being one nucleus, it now has segmented into three examples here. Sometimes it's four, sometimes it's two. But notice now that the granules by which these cells are defined, are named, have a kind of neutral beige kind of color when stained with this particular dye. So these are our major phagocytic cells, along with the macrophages. But these are the neutrophils that are in highest concentration in our blood. Some 60%, more than half of the cells in our blood are these neutrophils. So very important phagocytic cells defending against infection. Should an organism get into the bloodstream, it's there to engulf. Should an organism get into our skin, again, the neutrophils migrate from the capillaries into the infected tissue. But there are other cells that you may know and recognize, or at least are aware of their effects. So these are eosinophils, because the granules in the cytoplasm, here's the nucleus, but now here are all these granules, are a pink color. Eosinophils defend us against worm parasites, but also are involved in allergies. So for those of you who have hay fever or allergic conjunctivitis or allergies of one sort or another, if we took a sample of, let's say, the nasal discharge from you with allergic rhinitis and looked and stained it, we would see many eosinophils, because those are the organisms that are those are the cells that are involved in allergies as well as defending against worm parasites. And then lastly are the basophils, again, because now these granules in the cytoplasm are stained purple with this particular dye. And these are now involved, those of you who have had allergies, skin allergies, where, let's say, food allergies, and you have a hive, you have a swelling in your skin. These are the cells that release the histamine that causes the swelling in the skin. Okay, so sufficient to at least have an awareness that there are these different cells that perform different functions. The most important from our perspective, from an infectious point of view, are the neutrophils. All right, so we've discussed the various organisms that cause infectious diseases. We've talked about inflammation and a little bit about infectious diseases. Let's move on now to how bacteria, we're getting to the topic, how bacteria cause disease. So here's a model of a bacterium. Let's start at 12 o'clock and go around. So here's the chromosome lying free in the cytoplasm, single strand of DNA, single circular strand of DNA. And now coming around, here's the outer capsule. It's one of our most important virulence factors. It says, okay, I'm going to coat myself with this special covering such that when that neutrophil comes along, it can't get purchase. It can't really engulf. It sort of slides off. We fight back with antibody against the capsule that now has a handle on it, so to speak, that allows now the phagocyte to engulf because we have receptors on the surface of the neutrophil for the antibody that now allows it to engulf. That'll be talked about in the immunity lecture, but just want to introduce that idea. Suffice, if a bacteria cannot make a capsule, it cannot cause disease. It is engulfed and killed by our neutrophils very efficiently. So possessing a capsule, so-called antiphagocytic factor, the capsule extremely important as far as endowing an organism the ability to cause disease. Next is the cell wall. This is the site of action of some of our most important antibiotics, such as penicillins and cephalosporins. They prevent the organism from making the cell wall. So I'll just mention that in passing. It'll be discussed, I'm sure, next week at the next lecture. Not so important as a virulence factor for us tonight, but extremely important in the life of the organism. Here's the cytoplasm, where the proteins are made, and various other energy components are made. Moving around, here's the plasmid. I emphasized the importance of that, this extra chromosomal piece of DNA that encodes two very important proteins. Some of these virulence factors, the exotoxins in particular, that I'm going to talk about in a moment, and also the enzymes that provide antibiotic resistance You've heard, I'm sure, whether it's Staphylococcus or Neisseria gonorrhea, the cause of gonorrhea, that they are now resistant to penicillin. Why? Because they have acquired a plasmid that now encodes an enzyme that cleaves the penicillin ring and destroys the antibiotic. So plasmids, again, very important both from the point of view of encoding virulence factors as well as encoding antibiotic resistance. Flagella, not so important. It allows certain organisms to be motile, but not important for our discussion. Inclusions, also ribosomes, the site of action of important antibiotics, but not important for us at the moment. But the pilus, this hair-like projection that protrudes from the surface of the organism that allows the bacteria to attach to our cells, extraordinarily important. Organisms that cannot make a pilus are not pathogenic, cannot cause human disease. They must have the ability to attach to our mucosal cells, to our surface cells, in order to colonize and then to continue the infection. So of these various structures in the bacteria, the capsule and the pilus are extremely important virulence factors, and I'll have more to say about several others in a moment. Okay, so let me tell you a little bit about bacteria in general. They have three forms. The round spheres, I'll show you electron micrograph images of these in a moment. The round spheres are called cocci. Streptococci, staphylococci, gonococci, pneumococci. These are all different bacteria that have this round spherical shape. There are rods called bacillus. For example, the cause of anthrax is called Bacillus anthracis, a large rod. Then there are E. coli is also a rod-shaped bacteria, something that you all are familiar with. And then there are the spiral-shaped organisms called the spirochetes. Treponema pallidum, the cause of syphilis, it falls into this category. So let's have a look at some of these. So here's an electron micrograph of the streptococci. So here's a round organism, and remember they are in chains. I showed you those chains previously. Here's another round one, round organism. So the cocci are the spherical organisms, and we recognize these in the microscope. Very important fundamental property of these organisms. These, on the other hand, are rod-shaped. By the way, whether it's round or elongated is determined by the nature of the cell wall, by the particular chemicals, the amino acids and the sugars that are in the cell wall determines the shape, whether it's spherical or whether it's rod-shaped. So these are clearly different. These long rods, another long rod, and so on. So these are the bacilli. This happens to be Escherichia coli. And then lastly, here's the spirochete of Treponema pallidum, looking very beautiful, like a corkscrew, very unusual shape. The organism of Lyme disease, you've heard of that, it looks like this, falls into this category. So these are the three fundamental shapes that we recognize. Let's talk now about how bacteria cause disease and getting into some of the specifics. So the fundamentals of pathogenesis. Pathogenesis, to produce disease. The genesis of patho, the genesis of disease. So I like to think of it in terms of transmission. How are organisms transmitted to us? And then what happens once they are transmitted? They need to colonize, they need to attach to our cells and grow there, make more of themselves, and then they invade tissue, inducing either inflammation, which by itself causes the symptoms of the disease, or they produce toxins, which again mediate the disease, and I'll give you several examples of each of those. Talk a little bit about transmission. So here in this image, we have the infected host with these various organisms, and we have human-to-human transmission and then sort of non-human. So we all are aware that personal contact, whether it's shaking hands, sexual transmission, or by sneezing, coughing, can transmit organisms to the new host. There's also the form of indirect contact, where food is now contaminated by the person who is infected and then transmitted, and whether it's needles or a variety of other inanimate objects, all of these now can transmit. There's also organisms, whether they're insects, whether they're infected animals, very important source of infection for humans, and whether it's household pets or domestic animals in forms of cattle and sheep, or whether it's rodent in terms of rodent fleas and so on, then now can transmit the organism. The key is we must be aware how the organisms are transmitted to us in order to break the chain of transmission. Absolutely critical idea. We would much prefer to prevent disease than to have someone get sick and then treat them with antibiotics. So one of the fundamental ideas in prevention, aside from vaccines and sometimes prophylactic drugs, is to recognize how the organism is transmitted and to interrupt that chain. So we need to know where the organisms come from. They're usually acquired from an outside source. I noticed it usually, because I'm going to contrast that in a moment, called the reservoir. So the reservoir is out there, whether it's animals or soil or water. Most often, other humans and animals. But also soil, food, and water can be involved. However, infections are also caused by bacteria that live in or on our skin, mouth, and colon. They are called the normal flora. So right now on our skin, in our mouth, in our gastrointestinal tract, for those of you who are interested in topology, recognize that the inside of the colon is actually outside of the body, strictly speaking. That if you can think of it this way, that the bacteria that are in the colon are really fine there. They're just having a grand time replicating and feeding off the goodies that we eat, but they do not invade, or do not cause disease unless they invade the body. If you see what I mean, unless they enter tissue, unless they leave their space in the lumen of the colon, in the open area in the bowel, and then enter into that's when they cause disease. Okay, so we all have these normal flora. We all are on our skin. We all have the same kinds of organisms. And in fact, they actually do a good job in providing what's called colonization resistance. That is to say, the sites on my skin are occupied by these nice staphylococci, the good form. And it says to any pathogen that might come along, sorry, this site is occupied. I'm binding to this receptor, and there's no room for you, okay? Unless I get a cut or something where the organisms now, the bad Staphylococcus aureus, now is implanted into my tissues, sort of subverting the nice colonization resistance that's provided on my skin, or that's provided on my GI tract or my mouth, and so on. So these normal flora actually have a reasonable function, and we all have them. And so long as they remain in their appropriate place, we're fine with that, and they are fine with us. Okay, so that's a little bit about transmission, and this is sort of the classic picture. Is this going to transmit organisms? So just imagine how many viruses can be on some of these little particles. So we need to interrupt the chain of transmission, right? So this is what is recommended. So just to make a dramatic statement in that regard. Also, interrupting the chain of transmission, depicted here, it's the crude death rate for infectious diseases in the United States from 1900 to 1996. So here we are in 1900, 800 people die of infectious diseases per 100,000 population per year. And notice that the remarkable decline has occurred over the next 40 years or so, even before antibiotics were introduced. Here's penicillin in the mid-1940s. So why does that happen? We don't have antibiotics. It was a little smallpox vaccine was the only vaccine that was readily available. Because we interrupted the chain of transmission, because we disinfected, we chlorinated the water supply because we had proper sewage disposal, because we refrigerated food, because we pasteurized milk. All of these public health procedures interrupted the chain of transmission and provided remarkable decline in the incidence of infectious diseases in this country, even before antibiotics and other medical measures came along. Okay, so we've now, let's say, putatively transmitted the organism. The organism now needs to colonize and grow. So the bacteria attached by the pili, I mentioned those before, very important, these protein fibers that stick out from the surface, and I'll show you those in a moment, to receptors on our human cells. Why don't we do that right now? So here's the pneumococcus, Streptococcus pneumonia, by far the most common cause of pneumonia, overall cause of pneumonia, which is one of the leading causes of hospitalizations and death. Here's this pneumococcus, and all of these fibers are the pili that now provide the attachment of that organism to our respiratory tract cells and allow the organism to attach and then continue to grow. So very important. Again, if you don't make a pilus, that organism, any mutant that doesn't make a pilus is non-pathogenic, cannot cause disease because it cannot attach. Then there's this technical term, slightly complicated, but it's called a glycocalyx that helps adhere to the surface. It's a sugar coating, and let me describe the importance of that. Let's say we have a damaged heart valve, and we have some organisms from the mouth that now get into the bloodstream and have the potential for causing endocarditis, a very important, potentially lethal, potentially fatal disease. But picture now, let's say we have a damaged aortic heart valve, and each time the heart contracts, this volume of blood now swooshes past the damaged part of the aortic valve. So here's an organism from my mouth, gotten in the bloodstream, and now is trying to hang on for dear life with its pilus, and swoosh, all that organism is going to be dislodged from its site on the valve unless it plasters itself down. So the organisms that cause endocarditis are the glycocalyx producing strains. So the same organism, but unless it makes this particular, what's called a slime layer, or glycocalyx, or protective coating over itself, it will not cause disease because it gets dislodged. It might colonize momentarily, but the force of the blood dislodges it. So that's the most dramatic example of the importance of this virulence factor. Here's the capsule. We've talked about that before, that protects the bacteria from phagocytosis. Organisms that do not produce a capsule cannot cause human disease. And then lastly, the bacteria form a biofilm that protects the bacteria from phagocytosis and antibiotics. And it's a combination of these various factors. Let me just show you an image of that. So this is now the inside of a catheter. It's placed in a person's intravenous catheter, and some organisms from the person's skin, in the process of passing the catheter through the skin, some organisms have now gotten into the tip of the needle and then into the catheter. So here are some bacteria, and here are some yeast, much larger organisms, but you see this sort of a matrix, a film of all of this material now that has coated the inside of the catheter, that is now, when it gets a little bit larger, it now will cover these organisms and limit the ability of antibiotics that are in the bloodstream now to get to these organisms and kill them. Also limits the ability of neutrophils to get to these organisms and kill them. So the very contemporary idea of the importance of this biofilm in the ability of bacteria to cause disease. Okay, so now we have inducing inflammation. The presence of the organism is detected by the macrophages, the big eaters that I described, that then secrete proteins, technical term is cytokines, that say, okay, neutrophils, I'm in trouble here. Cyto meaning cell and kine meaning to move. I want you to move. You neutrophils out in the bloodstream, I want you to move to the area here where I am trying to engulf these bacteria, we need some help from the big eaters and from the neutrophils to now ingest and kill the organisms, and as a result, inflammation by the processes that I just described earlier now occur. And the resulting fluid and the exudate, now we're getting to the detrimental aspect of inflammation, where the fluid and the exudate decreases organ function. And the most dramatic example of that is in pneumonia. So let's say here's important for the oxygen that I inhale to get into what's called the alveolus, the little sac that's right next to the bloodstream and next to the capillary, and the oxygen has to diffuse across that membrane and get into the bloodstream to be picked up by the red blood cell and then taken to wherever the oxygen is going to be used. Well, if this inflammation now blocks the passage of the oxygen from the alveolus into the bloodstream, that's not good, right? That's clearly not. So you become short of breath, and that's one of the main symptoms of pneumonia, and it's because the oxygen is not passing into the capillaries, into the bloodstream, into the red blood cells properly. Now, some bacteria cause disease solely by producing inflammation. Others produce disease by producing toxins, and many of the toxins cause disease by themselves, even in the absence of the bacteria themselves, and I'm about to describe how that happens. So we're now moving to the sort of last phase of the talk, and that is to talk about how the toxins work. So there are two basic forms, the endotoxins and the exotoxins. The endotoxins are lipopolysaccharides, so they have a lipid component and a sugar component. Saccharides, as in saccharin, it's sugar substitute, but don't want to press that point. The lipopolysaccharides that are in the cell wall of the bacteria. I'll say more about that. And typically the bacteria need to be present in order for this to occur. And so let's talk about the endotoxins for a few moments. So lipopolysaccharide, abbreviated LPS. Endotoxin, major cause of death. People who enter the hospital with severe diseases, bacteria in the bloodstream, go to the emergency room, go to the intensive care unit, often die from endotoxin-mediated shock. And so it's the main cause of septic shock, fever, shock meaning hypotension, low blood pressure, and this is a technical term, and I'll describe it, but it has a fairly long name, disseminated intravascular coagulation, abbreviated DIC. So what that means is that in the millions of capillaries disseminated through all over the body, we're having clots form, tiny little clots that are inside the blood vessels. And so now think about if you had a clot there, you can't have oxygen exchange. The capillary is blocked, and so oxygen can't get into the liver or the kidney or the brain properly. And so the function of that organ deteriorates and declines, and that's why people die. Is we can handle the fever, we can support the blood pressure, a variety of methods, but people die because from septic shock, from this endotoxin-mediated shock, because of the clots that are in these tiny blood vessels that prevent the oxygen from getting into the tissue, and now the organ and tissue can't function. So you can see how that could happen. And I'll just mention that the lipid portion is actually the most toxic part. Let me just for a moment contrast what we call gram-positive bacteria and gram-negative bacteria, not getting into the specifics of why they are, but simply to say that in the gram-positive bacteria, there is a very thick cell wall and no endotoxin, no lipopolysaccharide outer portion, whereas in the gram-negative bacteria, they have a very thin cell wall and an outer membrane that is the place where the endotoxin is located. So if physician or you hear people talk about gram-negative shock or gram-negative septic shock or gram-negative rod sepsis or any of those terms, they describe the idea that these bacteria now have on their outer surface this outer membrane that contains this lipopolysaccharide that is the cause of the fever, the hypotension, the low blood pressure, and the DIC, the disseminated intravascular coagulation, that actually is the lethal event. And then just to close this segment, here's a blow-up of the gram-negative cell wall, and here is the thin peptidoglycan, the thin cell wall, and now external to that is the interior of the bacteria. Here is the lipid and the polysaccharide portion of the lipopolysaccharide, the endotoxin that I just talked about. Again, just to finish the endotoxin, it activates two main mechanisms. It activates the macrophages to produce these various factors, interleukin-1, tumor necrosis factor, nitric oxide, that mediate the fever and the shock, and also activates the coagulation cascade to cause the disseminated intravascular coagulation. So this now is the constellation of symptoms that compose septic shock, one of the leading causes of death in hospitalized people. Just to emphasize the drama of this disseminated intravascular coagulation, this patient had meningococcemia, a gram-negative coccus with endotoxin, and because of these tiny little clots in the small vessels in the fingers, also in the toes, but not depicted, this person now has gangrene of the digits, of the external portion of the digits. This person will lose this gangrenous portion of these on these fingers, and clearly this is inflamed and so on, because of the millions of tiny clots in all of these small capillaries. Dramatic example of disseminated intravascular coagulation. Okay, so that's endotoxin. Let's describe now some exotoxins. These are secreted polypeptides, so a completely different kind of molecule, and they can cause the disease with the exotoxin alone. You don't even need the bacteria. You can purify the exotoxin, leave the bacteria behind, inject the exotoxin into, hopefully not a person, but let's say an experimental animal, and reproduce the disease. So that's an interesting aspect. These are now secreted by the organism. So I just want to give you a couple of examples of this, and then a few last ideas, and we'll close. So here's botulinum toxin, known to most of you as Botox. This is what's being injected into your wrinkles. Okay, so watch the remarkable mechanism of action by this organism called Clostridium botulinum. So here we are at the neuromuscular junction, the place where the nerve ends and the muscle begins. So I'm contracting my arm because I'm sending a signal down this nerve. I'm now releasing the acetylcholine mediator contained in these vesicles. It goes across, I'll describe that, it's described in more detail here, now goes across this synapse, technical term for the space between the neuron and the muscle cell, and now attaches to receptors, and I can contract my muscle. So here on the left-hand side of this diagram is the normal way my muscle is contracting. Here's the acetylcholine, the red circles, contained in a vesicle. It's just sitting there, and along comes the impulse down the nerve cell and says, okay, release acetylcholine. The vesicle moves to the surface. Here comes the acetylcholine across the synapse. Here's the acetylcholine receptor, and now I can contract my arm. Botulinum toxin on the right-hand side, here's the toxin, binds to the surface of the neuron with this purple binding protein, now is incorporated into the cell, and the enzyme, which is a protease, something that cleaves proteins and is highly specific, now cleaves one of the releasing proteins. Name is not important, but it now is a protease that destroys this yellow protein. And sorry, the vesicle can no longer release the acetylcholine, and I get paralysis. I can't move my arm. Similarly, that's what's happening in the injection in the wrinkles, is that the muscle is relaxing and it smooths out the skin, and that's the plastic surgery or plastic aspect of cosmetic aspect of the use of Botox, and that's the mechanism. So again, we are getting what's called a flaccid paralysis, and I want to contrast that with tetanus, where you get what's called a spastic paralysis, a spasm. Now, why does that happen? Tetanus, we're all familiar with tetanus, we've all been immunized. This organism now also produces an exotoxin, but now we're in the spinal cord and we're blocking the mediators that, different from acetylcholine, that now activate the inhibitory neurons. I don't want to get into too much detail, but let me just describe this. So my ability to contract my arm is dependent not only on the ability to contract, but also for these muscles to relax. Otherwise, I couldn't do that, right? So something is telling these triceps and these other muscles, relax at the appropriate moment. Well, it's these inhibitory neurons that say, okay, triceps, relax, because I want to contract my bicep. Tetanus, the tetanus exotoxin prevents this inhibitory neuron from acting. So if the inhibitory neurons are inhibited, only the excitatory neurons are active, and I get tetanus, or tetany, or spastic paralysis, illustrated by this unfortunate gentleman, whose powerful extensor muscles of the back, so he's touching the ground by his heels and the tip of his head from the extraordinary power of the spastic paralysis of these powerful extensor muscles in the back. Okay, so now here's a question for you. I pose this to the medical students. This is a cartoon from the New Yorker. Honey, let's lay off the Botox for a while, shall we? Very cute, but wrong, right? Because she should be flaccid, not spastic. Aha. So now, next time you see a New Yorker cartoon, you can think about it. Yes. Okay, we're one more toxin and then a few last thoughts, and then we'll close. So here's cholera. Very important disease. Kills millions of people worldwide. Extraordinary diarrhea, watery diarrhea, prolonged watery diarrhea. Also exotoxin mediated. So here's the binding proteins, and we keep our eye on the red one. That's the actual active portion of the toxin. Here we are in the lumen of the intestine. In the open portion, here's the mucosa, rest of the body inside. Binds to the surface of the intestinal tract and injects or introduces the active molecule, which now stimulates adenyl cyclase. It's an enzyme, very important enzyme, to make more adenylate cyclase. For those of you who know about this, you know it's an important signal transducing agent, important mediator that transmits the signal from the surface of the cell into the interior, often to the nucleus, to tell it to do something. Very extraordinarily important. But in this case, this adenyl cyclase enzyme is turned on irreversibly. It just keeps making cyclic AMP, and there is a protein in the intestinal cell, which under normal circumstances is very valuable. It allows water to leave and a certain amount of sodium, a certain amount of potassium in order to keep the balance of the cells and the balance between the iron content in the blood and the iron content in the stool. It's functioning normally. But when it gets turned on irreversibly in large amounts, tremendous amounts of water and sodium and potassium and so on leave the tissue and end up in the lumen of the bowel and now manifests as watery diarrhea, persistent day after day of basically watery diarrhea that dehydrates and kills the person, all mediated by this exotoxin that activates the adenal cyclase. And just a word about cholera. So here are 3 views. This child obviously is comatose. Eyes are sunken, requiring intravenous fluids in order to activate. Here's a child who better off, still able to drink, able to hydrate, and no doubt will recover. And then lastly, this is called a cholera cot, such that the person with cholera is too weak to get up and literally go to the bathroom. So there's an opening here, and the diarrheal stool, persistent effluent, just passes into buckets, essentially, underneath the cot until the person either gets better or doesn't get better. So that's it's sort of a unique aspect of cholera. Okay, we're coming to the close. I want to just end with 2 important ideas, and that is, I mentioned that exotoxins now are made by the organism and can be liberated by the organism and now get into cells and do whatever damage they have to do, a la the botulinum toxin or the tetanus toxin or the cholera toxin. So that's depicted here on the left-hand side, where here's the organism and here's the toxin, and now it binds the receptor, gets into the cell, releases the enzyme that's going to attack the target and do whatever damage it is going to do. However, some organisms, clever devils that they are, have said, well, this is inefficient to just release it out. I'm going to bind to the surface of the human cell and inject my toxin directly. Much more efficient, much more effective. So this is, the technical terms, pathogen-dependent entry, not important for us, except to know that these organisms that have acquired this particular injection mechanism are much more virulent than the ones that do not. Mind you, having said that, botulinum toxin is the most toxic substance known to humankind, molecule for molecule. Because it's an enzyme and can keep on working, it is the most toxic substance known, as I said. Okay, lastly, I want to describe how an organism that is present in our intestinal tract, Escherichia coli, that you all know, can live perfectly normally in a mutually compatible relationship with us, and yet be an extraordinarily important cause of human disease. You say, well, how can that be? It's depicted here. It's because, something I've touched on before, it has acquired new genes, new DNA. So watch what happens. Here's this ordinary E. coli, but now here's a plasmid, we talked about that before, and now if this organism has acquired this plasmid that makes this particular protein, it now can cause dysentery. Dysentery is bloody diarrhea, often fatal, or certainly can be fatal. Alternatively, it can acquire a different set of genes and now cause watery diarrhea. You all know about turista. When we go to certain countries and we get this watery diarrhea syndrome from eating something, that's this E. coli that is making this different toxin that now is causing watery diarrhea. Also familiar with hemolytic uremic syndrome on the spinach. I have my little article here that I want to close with. That several people died from this E. coli on the spinach. Why did they die? Because they were infected with this particular organism that has now acquired yet different DNA that has now allowed it to encode completely different virulence factors. And now is the cause of hemolytic uremic syndrome, severe bloody diarrhea, and again, potentially lethal. Here's another example. E. coli is the most common cause of urinary tract infections, particularly in women, but in men as well. Why? Because it has acquired yet different proteins that now on the surface allow it to attach specifically to the urinary tract epithelium of the bladder. So no wonder it causes urinary tract infections. It can attach to our bladder's wall. That's why it has, this particular strain has the ability to cause urinary tract infections. And then lastly, it is the second leading cause of neonatal meningitis in newborns. Why? Because yet a different piece of DNA has now been acquired either as a plasmid or from a bacteriophage, a virus that infects bacteria, that now has a capsule, a specific capsule, that endows it with the ability to cause neonatal meningitis. So the thought that I'd like to convey is that organisms differ markedly in their virulence, in their ability to cause disease. And so then when you read in the Chronicle, dangerous E. coli bug blossomed this year, you'll say, oh, I remember that fellow told us why this happens. It happens because that particular E. coli now has acquired some new genes by one of these mechanisms, either the plasmid or phage or some of these others, and it endowed it with new capabilities to cause this particular severe disease. So in closing, where have we been? We've described the various types of microbes, the worms, protozoa, fungi, the bacteria, and the viruses. We discussed the concepts of infectious diseases, incubation period, prodromal period. We described the beneficial and detrimental effects of inflammation and what causes these effects. We discussed bacterial structure and its relationship to pathogenesis. We discussed the fundamentals of pathogenesis, the transmission, the colonization, invasion, and toxin production. We discussed the structure and action of endotoxin, we described the various actions of several important exotoxins. And lastly, we discussed how one bacteria can cause many different diseases depending upon the nature of its virulence factors. And so thank you very much for your attention. Thank you. So here are microorganisms evolving along with us. And what about other organisms? What about other primates and their... The one example that's coming to mind is human immunodeficiency virus in us and simian immunodeficiency virus in monkeys, for example. So independent evolution, here's this virus that's killing the helper T cells in these monkeys and chimpanzees and other primates, and at least to all intents and purposes until call it 1981, when it first really became obvious to us. But there's antibody evidence that we were infected perhaps a decade earlier than that. That this organism was causing disease in monkeys and then somehow changed in its nature or in its ability to infect us by mutation of that particular monkey immunodeficiency or simian immunodeficiency virus, and now allowed it to infect us. So yes, there are many bacteria and viruses. The field of veterinary infectious disease is enormous, but yet we continually interact, whether it's avian influenza virus, whether it's Lyme disease, whether it's, those of you who remember the hantavirus outbreak in the Four Corners area of the Southwest, where the rodent population, because of the El Nino, had more rainfall, more pinion nuts, more rodents in contact with people living there, more rodent droppings that contained the virus, more rodent droppings that dried out and were inhaled by the unfortunate people who got hantavirus pneumonia, and in 24 hours they were dead. Similarly, the Berkeley graduate student who went up to the Sierras to investigate some ecological project and rented a cabin and swept out the rodent feces, and 48 hours later was dead. So these are sort of dramatic stories, but it illustrates that there are animal pathogens continually circulating there, and we then now sort of intrude or are infected by either because of dose, the large amount that was swept up, or because the organism has changed just enough, like the avian influenza virus, it has changed just enough in its surface proteins to allow it now to infect our cells. What are the origins of viruses? You know, this is, yes, so often I have pondered, did viruses come first, or did we have to have cells in order to have viruses? Because viruses can only replicate in cells. The answer is I don't know. Intuitively, you would think that you would have to have a cell, and then somehow this piece of this nucleic acid acquired the ability to replicate independently, almost maybe plasmid-like, and then, don't know, but acquired the ability to coat itself with certain proteins, and then somehow acquired the ability to leave that cell and infect another cell. There's a lot of hand-waving going on here. But it's hard to imagine a virus as we know it existing prior to cells. I mean, there may have been self-replicating nucleic acids, but if a virus can only replicate within a cell, it seems to me it would have to have started as some aberrant form of nucleic acid from a previously existing cell.